My name is Dr. Robert Troell, a Stanford University trained facial plastic surgeon, also trained by the developer of tumescent liposuction. I have the honor and privilege of being the 5th surgeon in the United States to perform this revolutionary new technology known as water jet assisted liposuction, or the body jet. It is my pleasure to guide you through this presentation on the complete process of water jet assisted liposuction. A tremendous advantage of this body jet liposuction technology is the elimination of the need for any purification of the harvested fat to be used in both body and facial fat grafting. The body jet is manufactured in Germany by HumanMed. Eclipse Med is the sole U.S. distributor, which adds to its fractional carbon dioxide laser known as dot therapy. Modalities may be added to the standard tumescent liposuction techniques in hopes of providing a superior outcome, including ultrasound, power, and laser-assisted technologies. This water jet assisted liposuction video presentation is divided into chapters focusing on preoperative consultation, pre-surgical preparation, body jet device assembly, the infiltration phase, irrigation and aspiration phase, drying phase, and finally, the chapter on fat harvesting and fat grafting. The preoperative consultation on body contouring and liposuction includes the initial history, physical examination, and is completed by the surgical consent discussion. Once the patient has decided to proceed with the liposuction procedure using body jet technology and the sites of redundant fatty tissue they desire treated, the liposuction consent form is reviewed. General information highlighting all modalities of liposuction, local versus intravenous sedation, and the process is completed by discussing the benefits, limitations, risk, and possible complications. The most common side effects are skin contour irregularities and asymmetries. The American Society of Plastic Surgery has consent forms that can be purchased and customized to the surgeon's specifications. Pre-surgical preparation includes standard preoperative photographs, oral sedating medications, marking areas of liposuction, intravenous line and monitor placement, anesthetic solution preparation, surgical prep, and draping. Patient preoperative digital photographs are taken with adequate lighting in front of a cobalt blue background. Standard views include anterior, lateral, posterior, and one can also perform oblique views. These photographs are taken in the standing position. The next step in the pre-surgical preparation is patient marking. This is routinely performed in the standing position. A Sharpie marker is preferred on the body areas because it is difficult to remove during the prep. The perimeter of liposuction is delineated and the bony landmarks identified. Face and neck areas are marked with a surgical pen because it's easier to remove postoperatively. The areas for redundant fatty removal are identified with circles. Areas of indentations are identified with hash marks. The standard of care for any significant liposuction procedure is the placement of an intravenous line, cardiac monitor placement to include a pulse oximetry, blood pressure cuff, and EKG. The tumescent anesthetic solution is prepared preferably by the surgeon or a reliable professional personnel. Epinephrine, sodium bicarbonate, and lidocaine are used with normal saline. An alternative is to use lactated ringers. We use either a 3-liter bag or a 1-liter bag with the body jet technology. The bags are warmed prior to placing the medications, and when the medications are being placed in the bag, they are labeled by TS for tumescent solution. It's good to use the same sequence. I prefer to use epinephrine first, 1 amp in each bag of 1 liter saline. This is followed by sodium bicarbonate with a 1 liter bag, 10 cc's is used. And finally, 1% lidocaine. To caution surgeons, 2% lidocaine should not be placed in the operating room because double the dose can be given to the patient, causing lidocaine toxicity. Once the administration of medications is completed, the bag is placed on the BodyJet machine. The infiltration phase uses 50 cc's of 1% lidocaine per 1 liter bag of normal saline, and the irrigation and aspiration phase only 25 cc's. For patient comfort, the antiseptic solution is heated to about or slightly above body temperature. This is followed by the standard sterile patient prepping and draping procedure. I prefer sterile towels to large drapes, as this provides a more reliable sterile field. BodyJet device assembly includes aguar site lipo collector assembly, single-use tubing apparatus attachment, and BodyJet machine settings are applied. All components of the aguar-shaped lipo collector are organized before assembly. The assembly of the container insert commences with a perforated ring placed on the bottom of the container insert, followed by the fine filter, and then the retaining ring. The container insert is then placed into the collection container. The container seal is placed around the container lid. Place one end of the silicone hose onto the short attachment cylinder of the container insert, while the other end is placed onto the underside of the container lid. The O-ring is placed into the groove of the reducer, then the reducer is transferred to the peripheral hole on the container lid. Sterile saline is placed into the lipo collector and the lid applied. Secure the suction tubing from the patient onto the reducer of the lipo collector. The single-use tubing filter is placed into the BodyJet machine. Place one end of the suction tubing to the center of the lipo collector and the other end to the storage container located on the BodyJet machine. The BodyJet machine has two LCD screens, the left indicating tumescent solution flow rate from 1 to 5, the right indicating the total amount of tumescent solution used. The preferred flow rate is 2 or 3. The gauge position above the LCD screens records the vacuum force in millimeters of mercury. The BodyJet has higher vacuum force capabilities than typical liposuction machines. The infiltration phase commences with local anesthesia injected into the planned incision sites. I prefer to make incisions with a 2mm dermal punch. However, making small incisions with an 11 or 15 blade may be preferred. A 3.5mm infiltration cannula is attached to the single-use tubing apparatus and tightened. The infiltrator emits a pressurized fan-shaped beam of water at a 30-degree angle. Subsequently, the infiltrator is then primed by depressing the foot pedal to allow tumescent solution flow through the tubing. The infiltration phase of patient anesthesia begins with placement of the infiltration cannula through an incision. Then the tumescent solution flow starts by depressing the foot pedal. This phase should take only 1/3 of the amount of time and use only about 20 to 30% of the solution volume as a standard tumescent liposuction technique. An alternative method for this initial anesthesia is to use a standard infiltrator cannula, classically less than 2 millimeters in diameter, connected to a standard infiltrator machine. There are 3 different types of irrigation and aspiration cannulas of varying sizes. There are green, gold, and silver-handled cannulas. The edges of the holes on the gold-handled cannulas are dull, as opposed to the silver-handled cannulas, which are sharp. Gold-handled cannulas have 4 holes circumferentially, while the green-handled cannulas have 2 holes on one side only. In the initial part of the irrigation and aspiration phase, short, slow strokes are used, which can be altered to longer, more rapid strokes as the tissue resistance decreases. These movements are based on the observance of patient discomfort or blood in the suction tubing. When more discomfort is observed, shorter and slower movements should be performed. As can be observed here, long, slow strokes are removing fat cells with the absence of blood, atypical of the standard tumescent liposuction technique. The application of the water jet enables the surgeon to use less mechanical force during the liposuction process, thus creating less soft tissue trauma. This results in little blood contamination of the harvested fat. The drying phase uses no tumescent solution or irrigation, only aspiration of the residual solution. Typically, only between 200 and 500 cc's of tumescent solution is now retrieved, which is less than half of the standard tumescent liposuction technique. Because of the limited mechanical trauma using this water jet assisted liposuction technique, postoperative discomfort is decreased by 75%, swelling decreased by approximately 60%, and bruising decreased by more than 50%. The advantage is short-term of postoperative recovery does not compromise the long-term cosmetic outcome.